Okay, we're going to continue with care of patients with GI alterations, Part 7. First thing I'm going to talk about is cholecystitis. This is inflammation without gallstones. It's associated with biliary stasis that's caused by any condition that affects the regular filling or emptying of the gallbladder. Most cases of this type occur in patients with sepsis, severe trauma or burns, long-term TPN, multi-organ failure, major surgery, or hypovolemia. There are repeated episodes of cystic duct obstruction that cause chronic inflammation. Clinical manifestations include jaundice, icterus, pruritus, clay-colored stools, urine is dark and foamy. There is such thing as chronic versus acute. Acute can be calculus or acalculous. There is a chemical irritation and inflammation that result in gallstones, which obstruct the cystic duct, gallbladder neck, or common bile duct. The trapped bile is reabsorbed. They may have edema, impaired circulation, and gallbladder distension, which causes ischemia and infection, results in tissue sloughing and gangrene, and it can rupture and lead to peritonitis. Calculus is the most common type, and it results from gallstones that obstruct the cystic duct. Most common with obesity, people that are older than the age of 60, diabetes mellitus. Sometimes it's associated with the American Indians and the Mexican Americans. Think of the 4 F's: female, 40, fat, and fertile. After fatty food, they may have flatulence, dyspepsia, or eructation. So they may also have biliary colic, which is a spasm that occurs in an effort to mobilize the stone. They may have prostration, possible shock. They'll have elevated white blood cells, AST, LDH, and direct and indirect serum bilirubin. The abdominal x-ray may show calcified stones. They may have an ultrasonography of the right upper quadrant. It's the best diagnostic test for cholecystitis. They may have opioid analgesia, anticholinergic drugs such as Bentyl to relax the smooth muscle. It's not used in the elderly. They may have antiemetics, antibiotics, intracorporeal shock, wave lithotripsy, percutaneous transhepatic biliary catheter, and laparoscopic cholecystectomy. They traditionally used open approach, and it's used in patient that has chronic lung disease or heart failure. If a T-tube is placed in the common bile duct, make sure the T-tube is not raised above the gallbladder level. See chart 62-2, page 1370. They may need a low-fat diet after surgery. They may have repeated abdominal or epigastric pain with vomiting that occurs weeks to months after surgery. It occurs about less than 10% of patients. Causes are caused by pseudocyst, CBD leak, duct stricture, sphincter of the OD dysfunction, retained or new gallstones, mass, and etc. There's a table on 62-2, page 1371 of your textbook. ERCP may be done to find the reason and to repair it. Then we have gallbladder cancer. It is rare. It is more common in women than men. Signs and symptoms can be anorexia, nausea, vomiting, weight loss, abdominal bloating. They may have fever, general malaise, jaundice, enlargement of the liver and the spleen, severe abdominal pain, and it's usually diagnosed in the late stages. I'm going to talk about acute pancreatitis. Jaundice occurs from the swelling of the head of the pancreas, which slows the bile flow. There is calculi or pseudocysts that may constrict the ducts. They may have hyperglycemia. There's atelectasis and pneumonia or pleural effusion of the left lung. They may have a multi-system organ failure. They may have acute respiratory distress syndrome. They may get DIC, paralytic ileus. They may go into shock, which is a vasoactive substance released. Many are unknown causes, such as excessive alcohol, biliary tract disease, such as gallstones, post-surgical manipulation. After an ERCP, they may have anti-secretory agents. It could be caused from trauma, such as blunt force, obstruction of the pancreas, metabolic disturbances, renal disturbances, viral infections. It could be drug-induced. Rates are increased during holidays and vacations, especially in men. Women are affected more after gallbladder disease and within 2 months of childbirth. Prognosis is poor for alcohol-related pancreatitis. They will have severe abdominal pain in the mid-epigastric area or left upper quadrant. Pain will have a sudden onset. Pain is boring and increases with lying supine. They may have nausea, vomiting. They will have a Cullen sign, Turner sign. Mass may be present if pseudocyst is present. They will have an increase in serum amylase, lipase, bilirubin, AP, ALT, white blood cell, ESR, glucose, BUN, and triglycerides. There will be presence of C-reactive protein. They will have a decrease in serum calcium and magnesium with fat necrosis. Calcium levels below 8 will consistently have a poor prognosis. Platelets are used up, and albumin also decreases. They move out. There could be a contrast-induced CTE to provide the most reliable image and diagnosis of acute pancreatitis. The abdominal X-ray may show gallstones. The chest X-ray may show elevation of left diaphragm or pleural effusion. You want to provide supportive care by relieving symptoms, decrease inflammation, and treat complications. Abdominal pain is the most common symptom. You want to hydrate with IV fluids. They may have fasting and rest. They may have an NG tube. So you're going to think about nutritional interventions, opioids and antiemetics, histamine receptor antagonists and PPIs, antibiotics. If gallstones are present and can't be obtained by other procedures, they may have to think about that. Then we have the pseudocyst and abscess that may require surgical removal. This may be done by an MIS or conventional approach. We're going to talk a little bit about chronic pancreatitis. Think about this. How is it different than the acute? How's the treatment going to be different? How do you know if enzyme treatment is effective? You want to be able to discuss medication replacement for pancreatic enzymes. Know the patient teaching that you're going to want to include related to these enzymes. So I want you to review chart 62-3 on page 1327 of your textbook for this information. So pancreatic abscess is the most serious complication of acute necrotizing pancreatitis. It will be fatal if it's not treated. Purulent liquefaction of necrotic pancreas. These patients are more ill than the patient with pseudocyst. They have a temperature as high as 104 degrees. CT can actually differentiate. So pancreatic pseudocyst is an encapsulated sac-like structure that form on or surround the pancreas. The wall is inflamed, vascular, and fibrotic. It can contain up to several liters of straw-colored or dark brown viscous fluid. It has to be surgically drained or can be surgically drained. The fistula development with skin breakdown is a complication. With pancreatic cancer, it's difficult to diagnose, and there's a 5-year survival rate, and it's very low. Maybe primary or met site. There's venous thromboembolism that is the common complication. There's a genetic consideration. I want you to look at the key features on page 1381 of your textbook. There is radical pancreatopseudocytectomy, and it's used to treat the cancer of the head of the pancreas. And what they do is basically remove the head of the pancreas, the duodenum, a portion of the jejunum, and all are part of the stomach and the gallbladder, with anastomosis of the pancreatic duct, CBD in stomach. This concludes the last part of GI alterations. If you have any questions about this lesson, please contact the instructor.